Hi, thank you for joining us for Utilising Nurse visits under Medicare to ease pressure on GP shortages and improve patient outcomes. My name is Phoebe James and I am a Professional Development Officer with the Primary Health Network. Before we go any further, I would like to acknowledge the traditional custodians of the land we are all meeting on today and pay my respect to elders past, present and emerging. I just wanted to mention, before we start, that this session is being recorded. The recording and the PDF slides will become available on our PHN website in the Education Library in the next few days. There is also an evaluation that needs to be completed at the end. I would be eternally grateful if you could fill this out for me. Today, we have Sarah Houlihan, who is a Primary Care Improvement Officer with the Primary Health Network, and I'll hand over to Sarah now.
Thanks, Phoebe. So I too would like to acknowledge the traditional custodians of Darkinjung land, where I live here on the Central Coast, and offer my respects to any First Nations people who are joining us today. I'd also like to thank my colleagues Heidi Avery and Ashley Bullock for their contribution to today's presentation with questions regarding MBS and First Nations health. So our learning objectives today are around obviously identifying why we want to use nurse item numbers, how we can utilise nurse visits, and tools and ideas for how we can implement these into our daily practice. So straight up, although today we'll use the term nurse item numbers, we recognise that all MBS billing is claimed from Medicare via the supervising GP. It's also important to note that whilst there are some item numbers for use by nurse practitioners, diabetic educators, mental health nurses and Aboriginal health practitioners and workers, today's presentation is relating to services provided by our registered and enrolled nurses for and on behalf of a GP. So these are our practice nurses. Billing for nurse item numbers should usually be submitted by the patient's regular GP, who retains overall responsibility for the patient's care. The GP should be confident that the nurse has appropriate training and skills to perform the service under remote supervision. And practices should have a written clinical risk management strategy covering issues like clinical roles, patient follow-up, and patient consent relating to nurse services provided for and on behalf of the GP. And as is the case for all aspects of team care, doctors should consult their insurer regarding indemnity coverage for any service which is performed on their behalf. So there are 4 item numbers in the MBS relating to nurse services. So the first one that we're probably most familiar with is the 10997, and this is for patients with chronic and complex health conditions requiring a coordinated approach to care and who have a current GP management plan or team care arrangement. The 5 nurse services each year can be provided face-to-face or via telehealth or telephone. Monitoring and support nurse activities need to be consistent with the goals and treatments outlined in the care plan, and it is not appropriate to bill a monitoring or support service for the development of a GPMP or TCA, as obviously the patient goals and plan need to be established before we can monitor or support progress towards them. Our next most common item number for nurses is that 10987, and this is for First Nations people of any age with a 715 health assessment. So the 10 nurse follow-up visits per calendar year need to be consistent with the identified needs, goals and treatments in the health assessment. These services can also be provided face-to-face or via telehealth or telephone, and the follow-up services are designed to maintain regular monitoring and relationship building over the course of the year. The 10983 item is for situations where patient and nurse support is required for a video telehealth consult with a specialist. So prior to January this year, this MBS item had location restrictions. However, it's now available to all patients Australia-wide. The nurse or Aboriginal health practitioner or Aboriginal health worker are not required to remain with the patient throughout the entire consult unless requested by the specialist. And then finally, the 16400 antenatal service is available only to patients living in rural and remote areas and cannot be billed on the same day as a GP antenatal consult. If antenatal nurse services are relevant to your location and your level of training, please refer to the associated notes in MBS Online regarding the requirements and restrictions for use of this item number. So nurse visits benefit everyone as we reduce gaps in care, reduce waiting times, reduce pressure on GP time, reduce ad hoc visits, and reduce potentially preventable hospitalisations. In contrast, we increase continuity of care, increase multidisciplinary care, and importantly, we increase patient engagement in self-management as they feel partnered with their medical team. We also learn to work smarter rather than harder as we utilise the scope of nurse knowledge and skills and provide a cost-effective model of care, which is subsidised by both Medicare and Services Australia by the workforce incentive payments. How you use nurse visits should be determined by the clinical needs of each patient. For example, a patient who is stable and generally has good management of their conditions may benefit most from planned visits in between care plan reviews. A responsive approach might be more appropriate for patients with a new diagnosis, progressive deterioration, or a recent hospital visit. In these instances, you might provide frequent nurse visits, say for a few weeks, while the patient's being stabilised, followed by some planned visits for ongoing monitoring. And then finally, opportunistic visits are where the patient is already in the practice for another reason, like a GP consult or another service with the nurse, and the opportunity is taken to check in with the patient regarding their goals of care, or where the nurse has time in their daily schedule to initiate a telehealth or telephone consult, and the patient consents to discussing their progress remotely. So what can be done during a 10997 nurse monitoring and support for patients with chronic disease? The first thing the MBS outlines is checks on clinical progress and access to services. So the things that we would most likely be doing in our day-to-day for these patients might be things like blood pressure monitoring, weight and waist measurements, checking on attendance with allied health, eye checks, dental checks, checking that the patient has access and attendance and that we've received reports back. ECG, ABI, contributing to cycles of care. Audiology, where hearing is affected by the patient's conditions, maybe some foot and leg checks, an MMSE or K10 if chronic conditions are affecting mental health, and diabetes, cardiovascular, or kidney health checks that are relevant to their existing chronic conditions. The next point that the MBS says for follow-up of chronic disease items is around self-management advice. So this is where we address the various risk factors for disease progression and all the other determinants of health and well-being, like your SNAP assessments, looking at mobility and movement, education regarding any devices being used at home, like a blood glucose monitor, a home blood pressure monitor, or a peak flow meter, discussion around home safety equipment or aids for managing life with chronic disease, support for personal, career or education goals where chronic conditions may be a factor, and connection with appropriate groups or services like Get Healthy, Quitline or peer support groups. The third point in the MBS for monitoring of patients with chronic disease is around medication compliance. So when we're monitoring medications, we're again looking at that bigger picture. So checking the patient's understanding of the medications they take, asking about any potential side effects they might be experiencing, which could lead them to cease taking the medicine without notice, looking at things like if the patient might benefit from dosing aids like a pill box or a Webster pack, whether they need to set alarms to remind them to take medications at certain times, looking at what pharmacy services are available to them, like home delivery, script management, and reminders when their refills are due. We might be giving advice to the patient regarding e-prescriptions, registering with pharmacy for active script list to help them with token management, and documenting the use of any complementary or alternative therapies which may potentially interact with the prescribed medications. And then the fourth point in the MBS for 10997 monitoring of patients with chronic disease is around collecting information to support the review of a care plan. So this might involve things like collating or chasing reports and results, facilitating pathology or radiology testing, discussing with the patient what their goals might be for the year ahead, and assessing their change readiness for the goals that they set. So as you can see here, the 10987 follow-up services enable all the same interventions we discussed for the 10997s, where relevant to the identified needs and goals outlined in a patient's 715 health assessment. With our First Nations people, however, we can also address risk factors and prevention strategies, and we have 10 nurse follow-up visits each year. The regular monitoring of health and wellbeing enables us as nurses to contribute to national Close the Gap targets to improve health disparities between our Indigenous and non-Indigenous Australians. And specifically related to today's topic, we can work on helping Aboriginal and Torres Strait Islander people enjoy long and healthy lives by closing the gap in life expectancy. We can help Aboriginal and Torres Strait Islander children thrive in their early years by increasing the proportion of First Nations children assessed as developmentally on track in all 5 domains of the Australian Early Development Census. And we can ensure Aboriginal and Torres Strait Islander people have access to information and services, enabling participation in informed decision-making regarding their own lives. So when it comes to documenting your nurse visits, you're required to do the same documentation as any other consult. That is, of course, the notes must be written contemporaneously. They should contain enough detail for another health provider to provide continuity of care. Any measurements or assessments should be input into the correct section of your clinical software to facilitate data comparison over time. Free text into progress notes doesn't allow for you to be able to see graphs and measures where we can see if there's any change over time. Specific to the 10997 and the 10987 item numbers, the note should also document which service, education, assessment or treatment was provided, and note how this visit is consistent with the goals of care. And the supervising GP should only ever bill nurse item numbers where there is documentation by the nurse to substantiate that the service was provided and meets MBS requirements. Now, relating to those 10987 items that we were talking about, so following up for our patients with 715 health assessments, obviously we want to start by identifying who our Indigenous patients are by asking them appropriately, are you of Aboriginal or Torres Strait Islander origin? Once we have that recorded in our software, we can offer to register them for the Closing the Gap PBS co-payment relief and record that in our software. And the other program that I wanted to just remind everyone about, because it is related to chronic disease management for our First Nations people, is the integrated team care, as providers can be included in the care team for First Nations people with specific chronic conditions who might require additional support. So other services to help you with support, monitoring and follow-up are listed here, and each of these are essentially a topic of their own. So I've included links in the slides, and they'll be available to you in the PHN Education Library this week if you wanted to learn more about any of these. Over the coming weeks, you're likely to hear discussions around the ceasing of item numbers for the diabetes and asthma cycle of care and for cervical screening. It's really important for us to remember that these services absolutely can and should be completed as best practice care for our patients. It is only the billing structure which has changed. These three things will now be billed under attendance items, which, to be honest, actually pay slightly more than what the cycle of care numbers did anyway. So we are not losing out here. We're just having a change to manage. In terms of tools to assist you with support, monitoring and follow-up, there's lots of different programs that can assist you with management of chronic disease and following up on health assessments. Each have their own pros and cons, often with a cost attached to them. These tools, however, are already available to your practice and completely free. So on the top left, we have Top Bar, and this is a point of care tool that shows all kinds of information, but for the purposes of this presentation, it helps us with seeing patient eligibility for nurse follow-up visits. In the middle, we have an example from a quarterly data dashboard provided to your practice by your PCIO. Bottom left is our PenCat or CAT4 program, which can be used to identify cohorts and individual patients with certain conditions, patients taking certain medications, the services patients may have received or may be eligible for. And then on the right, we have some examples from a LUMOS report, which is a New South Wales Ministry of Health data linkage program that provides insight into your patient's engagement with health services outside of your practice. The examples of extracts I've included here are particularly relevant when we're discussing nurse visits, given that they look at things like unplanned hospitalisations, ED triage categories, patients both with and without chronic conditions attending hospital, access to care before and after hospitalisation, main diagnosis in hospital, and additional diagnoses managed whilst they were in hospital. So if you don't currently have access to any or all of these programs and would like to know more, please reach out to your primary care improvement officer and we can absolutely help you with this. Now, if anything that I've mentioned today has piqued your interest, or if you would like to learn more around chronic disease management and health assessments, any of these services will be of benefit to you. Services Australia have recently updated their health professionals e-learning pages. APNA have got the chronic disease and healthy ageing program, as well as many other CPD programs available. Benchmark often have fully funded or heavily subsidised training in chronic disease management, all aspects of it. And of course, our CVC program for patients who are looking after our veterans. So thank you everyone for giving us your time today. I know it is valuable. And I appreciate that you've stayed with us. Phoebe, did we have any questions for today?
We did. I just wanted to apologise to everyone. I did forget to say to put your questions in the question box. I did send out a chat, but get the questions in quickly so we can answer them. We did have one come through from Kate Webb asking, can we bill both 10997 and 10987 if Aboriginal and Torres Strait Island and on a care plan?
You can, provided that you have met something different for each of them. So if you have provided for that patient, say, 2 different services in the same day, and one of them is to meet the goal of the chronic disease management and one of those is to meet the goals of the 715, then absolutely. But you wouldn't tack on both for just one activity. So, but yes, you can bill you can co-bill those items. With most co-billing now, it is best, I know nurses don't tend to do this, this is more admin, to actually put timestamps on when they were provided, because then that shows that they were 2 separate services.
Okay. And if a nurse does a phone follow-up, is that included in the GP's 30/20 rule?
Oh, good question. So this is a very recent change. So yes, the 30/20 rule has come in just this week for our GPs. So this is talking about the telephone attendances where they're only allowed a maximum of 30 telephone visits for up to 20 days per year before they're sent for review. Um, yes, the telephone item numbers are inclusive of any service that is provided via telephone. So if you are doing a lot of remote monitoring of your patients, it might be worth looking into those telehealth services via video because they are not included in that 30/20 rule.
Okay. Well, we haven't had any other questions come through, so I'd like to thank you, Sarah, for your time today, for your presentation. It was very helpful. Thank you to everyone for attending. You will be sent out an evaluation, and I would consider it a personal favour if you complete that for me. But other than that, everyone stay safe, look after yourselves, and thanks a lot.
Great, thank you.
Thanks, Sarah. Bye.
Okay, bye.